Very much. I will be a little bit out of this business now, and we move towards assisted ventilation or conflict of interest for this presentation. This is just to show that recent data suggests that assisted mode, mainly pressure support and BiPAP, are more and more used in the setting of critically ill patients. There are some rationale for assisted ventilation, as you can see here from studies mainly by Putensen group, showing that with spontaneous ventilation you decrease the pressure in the pleura, and so you increase the transpulmonary pressure at least at the beginning. This may promote further recruitment of the lung. On the other side, the possible negative effects that even if you apply the same RE pressure, mainly in pressure control or pressure support, when you have a more negative pressure in the pleura, of course you increase the transpulmonary pressure, and this can further damage the lung as shown before. So there are some positive and negative issues related to assisted ventilation. Then there are other issues that has been investigated in different studies. Assisted ventilation may be associated with less need of sedation, less need of vasoactive drug, perhaps better perfusion of the gut mucosa, and there are several studies, including those from Samir, showing that we have reduced the muscle atrophy and proteolysis on the muscles. Now I refer to two studies, animal studies from Yoshida group, and he worked also with Marcelo Amato. This is one of them, very interesting. They look at animals with lung injury model with low tidal volume and what they call moderate tidal volume, with spontaneous breathing weak or strong, and this is the transpulmonary pressure, and this is the occlusion pressure. As you can see here, they found that when they ventilated with low tidal volume and a low spontaneous effort, so you see here PO1 1.5, there was a little bit degree of injury. There was less degree of injury when the animals were ventilated with a low tidal volume, but with a little bit higher, they call stronger, inspiratory effort, so the transpulmonary pressure increased. When they ventilated with moderate tidal volume, but with weak or strong, so increased transpulmonary pressure, there was a further damage. What we can get information from this animal study, that if we ventilate with very low spontaneous breathing, we have some damage. If we ventilate with higher inspiratory effort, we can make damage. So it's like a U-shaped curve. The same group published another recent paper, and this study is also, I think, interesting for the translational view, with animals with mild lung injury without and with spontaneous breathing, and with severe lung injury without and with spontaneous breathing. And you can see here, this is the esophageal pressure, and you see that in the mild injury, this is the pattern of swing of the esophageal pressure. This is the higher swing that you have when we have a higher injury. So this data suggests that if you apply increased spontaneous breathing in animals with very severe lung injury, this can further damage the lung, while this can be protective if you apply this in animals with less injury. So what's going on? So first of all, I refer to studies that we performed in Rio de Janeiro with my friends Patricia Rocco and Felipe Sedi in small animals. This is the first study we published in, experimental models of lung injury. This is the different inflammatory mediators. This is in the pressure control ventilation, so the animals were ventilated always with protected tidal volume, but in controlled ventilation. This is with assist pressure control, so the animal can breathe, but this is time cycled with a ratio of 1:2 or 1:1, and this is with BiPAP and spontaneous breathing assisted with pressure support. You see that in the first message here that we found a reduction of inflammatory mediators wherever some assisted breathing was given. On the other side, we also found that when we substantially used a mode of ventilation like BiPAP pressure support, we promoted further spontaneous breathing. This was associated with a further reduction in the inflammatory mediators. So more controlled this ventilation with protected tidal volume, this was associated with a little bit higher injury as compared when we applied a BiPAP plus pressure support. And we did another study we recently published in which we look in BiPAP a different level of work of breathing. You see here again the baseline in the pressure control, and then when we ventilated animal in BiPAP with full ventilatory support, when we maintained 25% of spontaneous breathing or 50% of spontaneous breathing. And you see that we found that in different models with pulmonary or extrapulmonary lung injury, increasing the inspiratory effort in mild acute lung injury, so this is not severe lung injury, this is very important to be compared to the data by Yoshida, we've observed less activation of inflammation. Then we move on to the big animals, and we did these studies in Dresden with Marcelo Gama de Abreu and a full group of friends. This is one of the first studies we performed, was in controlling animals, big animals, with pressure controlled, in pressure support. I don't want to touch now noisy pressure support. First of all, when we ventilated in pressure support, these were a little bit more severe lung damage. You see that in pressure control, the PO2 FR2 was around, anyway, 180 with PEEP. When we ventilated in pressure support, the PO2 increased with no major changes in CO2. What about transpulmonary pressure? This is interesting to me because what we found, this is the transpulmonary pressure on average that we found in pressure control when animals were completely, fully paralyzed. When animals were ventilated in pressure support with adequate sedation, so we try to maintain not excessive inspiratory effort, but just enough the patients to trigger the ventilator. This is, again, is very important to interpret this data. You see that the transpulmonary pressure was not higher, but was lower as compared to pressure to control mechanical ventilation. Of course, if we would maintain a sedation much lower, it's very likely that we have increased transpulmonary pressure, we get different results. And in fact, from this study, you see on the right, the DAD score, the anatomical damage score of the lung, was reduced when we ventilated animal in pressure support as in pressure control, both in non-dependent and dependent lung region. And this was also associated with a reduction in inflammatory mediators. Then we published another study. This is, again, a very similar study we performed in rats, but this was performed in bigger animals. Again, you see different level of BiPAP, full control, and then we reduced the rate of BiPAP in order to increase further and further the spontaneous breathing. Again, we found that increasing the level of spontaneous breathing, you see the oxygenation increased. Again, when we look at here is the level of transpulmonary pressure at the full control respiration, or when we added spontaneous breath, and this is the total, you have to look of this level, you see that increasing the amount of spontaneous breathing, but maintaining adequate sedation and not increasing too much the inspiratory effort, so sedation and spontaneous breathing has to be carefully balanced. We had a reduction in transpulmonary pressure and not an increase of transpulmonary pressure as compared to controlled mechanical ventilation. As a consequence, as you can see here, the damage score in the lung, anatomical damage score, progressively decreased when we increase further the amount of spontaneous breathing up to 50% during BiPAP, as compared to the full control mechanical ventilation in black. And this was also, again, this is just one of the mediators that we measured in the lung and in the blood. You see that there was a progressive reduction in the biochemical inflammation in the lung when we increased the amount of spontaneous breathing. Then we look more carefully at what happened to the lung and the perfusion when we move towards assisted breathing. These are the different level of support, fully support, and here more assisted breathing. These are atelectatic areas that you see are reduced markedly when we increase the spontaneous breathing at this level, as we expect from the theory. And this is the perfusion by PET. And you see here that the amount of perfusion, even if we've observed an increase in the recruitment due to the increase in the amount of spontaneous breathing, was not changed. The overall matching between ventilation and perfusion was there was an improvement in VAQ in these animals. So this data, we showed that the increase in spontaneous breathing was associated with increased recruitment, with no redistribution of blood flow in this study, and so a better improvement in the VAQ mismatch. In other studies, we found something different, mainly in pressure support. This is in BiPAP. In pressure support, we found something different. In pressure support, we found less recruitment and the improvement in oxygenation as a redistribution of blood flow. So the blood flow during assisted ventilation is a little bit more complicated. However, when we look at the overall lung strain, you see that since we increased the lung volume at end expiration and the tidal volume was maintained at constant protected, the lung strain was reduced. So the stress was reduced, as I showed you before, due to the reduction in transpiratory pressure, and the strain also was reduced. Then I want just to finish with another study we performed just comparing different types of assisted breathing. You see pressure support, in this case PAV, and we also in this study, we included noisy pressure support. We have other studies looking at the effect of NAVA, for example. Just to give you some insights in this field, you see here that when we applied PAV, or noisy pressure support, which is a sort of variable pressure support, of course the variability of breathing was much higher, around 20–25%, as compared to conventional pressure support. So proportional assisted ventilation is associated with an increase in the variability of breathing. However, when we look at the different mediators or diffuse alveolar damage score, we did not find any difference. This is completely different from the studies that I showed you before. So assisted breathing, wherever form it is, was associated with less injury, but when we start to compare different forms of assisted breathing, it was more difficult to find differences in the lung damage. This is the first study that we published on patients related, for example, to the comparison of variability of breathing by using noisy pressure support and pressure support. What we found, this was just a physiological study, that noisy pressure support, so when we increased the variability of breathing during pressure support, this was associated with a better patient-ventilator interaction, surprisingly, because we would have even expected a different case. And this is a large randomized controlled trial, which is now ongoing. We are more or less at the half of the study. I think we will be completed in 1 year and a half, in which we are comparing pressure support and noisy pressure support on the WINI in a large population of patients. And we will see the results, I think, in 2 years, in 1 year and a half. So just to conclude this talk, why assisted ventilation can be associated with less ventilator-induced lung injury if we maintain protecting mechanical ventilation with low tidal volume, not too excessive inspiratory effort, and adequate sedation. This is what happens during controlled mechanical ventilation. So we have an increase in the airway pressure in the alveoli. The lymphatics are squeezed due to this pressure, and usually perfusion is towards the most dependent part of the lung, impairing VAQ match. During assisted ventilation, with the issues that we discussed before, we are able likely to maintain a more aerated lung. The lymphatics are less compressed because we have a little bit negative pressure in the pleura, and the distribution of perfusion can further improve oxygenation in our patients. On the other side, this different distribution of pleural pressure, that means it's more negative in the pleura than during controlled mechanical ventilation, is likely to be associated with less epithelial damage, as we showed in these animal studies, less extracellular matrix damage, as we also showed in previous studies, less endothelial cell damage, and overall associated with less local inflammation and less local fibrogenesis. To conclude, controlled mechanical ventilation may lead to loss of aerated lung volume and likely atrophy and proteolysis of respiratory muscle. So if we are able to avoid as much as possible, we believe that this is the best way to go. The early resuming of spontaneous breathing or partially assisted breathing can have some positive effect, as mentioned here. There are some in animal models, we and others showed that this can be associated with less ventilator-induced lung injury, but if we consider the use of low tidal volume, adequate sedation, and not excessive inspiratory breath. Which is the optimal assisted breathing has to be determined. From our data, it seems that pressure is better than volume in assisted breathing. Likely, our data suggested BiPAP, so time cycled, and you preserve the time and the mean airway pressure during inspiration, is a little bit better likely to pressure support. It's probably better to go to BiPAP and eventually later to pressure support in the weaning phase. We don't know too much about the comparison with different other types of assisted breathing. How much inspiratory effort should we give? We don't know in patients, but we know that we have to maintain at least 30 to 40% of spontaneous breathing during assisted breathing to optimize the efficacy of assisted breathing in our patients. I showed you the differences for what commonly believed. If we titrate adequate sedation, we can get lower transpulmonary pressure during assisted breathing than during controlled mechanical ventilation. And of course, this depends on the level of support and the level of sedation. Finally, animal data also show that this strategy can be, of course, more beneficial in conditions in which we have mild to moderate lung injury. So personally, we try to be very careful to use assisted mechanical ventilation in the early phase of RDS when PO2 FR2 is lower than 150 with PEEP higher than PEEP of 5 of 10. So when these parameters are higher than 150 with around PEEP 10, we immediately move towards assisted breathing. Of course, clinical studies are warranted to definitely prove that assisted breathing can be really helpful to improve outcome in different categories of patients as compared to controlled mechanical ventilation. Thank you very much.
Thank you.